I'm Dr. Sarah Duvall, physical therapist, and I want to welcome you to our lesson on returning to sport after pregnancy. Now, this is a topic that is very dear to my heart as being a mom myself and as someone who has helped many women through difficulties during this process. So, we're going to start by looking at the physical changes that occur during pregnancy and delivery and how they can present as issues for women trying to get back into their sport. Now, I'm going to call these women athletes because we are, don't strip that title away from us, even if we're only going for a 3-mile jog a couple of times a week. Okay, so when we use the term, when I use the term in here, athletes and returning to sport, I'm using that kind of interchangeably with people who want to be athletic, with people who are striving toward goals and women who want to do more and be active after pregnancy. So we're going to take a look at how we can mitigate some of those risks through great rehab postpartum. And even though I'd love to cover everything on this topic, there's just too much to cover. So my goal here today is to give you a little bit to take away. So something where you can adapt a treatment plan right now, maybe immediately recognize something. So let's dive in. We're going to have some fun. So our job is to help women learn what to listen to. I know you've heard the saying of just keep doing what you're doing or listen to your body. But frankly, the women who are better at athletics tend to be worse at listening to their body. At least that's what I found with dealing with athletes that are able to push and ignore those pain signals. They're able to keep going past when us mere mortals would probably say, oh, this burns too much. And so we have to help athletes take a step back and learn how to listen to their body and learn what to listen for. I mean, how many times have you treated somebody that kept running or cycling or swimming through the little tweaks, the hip flexor tightness, the low back discomfort, the shin splints? You know what I'm talking about. These are women who like to push instead of listen. All right. So they just deal with these issues while they're in their training. So pregnancy often exposes our cheats and our weaknesses. And then this gets worse during that postpartum time period. And so it can be a very frustrating time period for women. Maybe they'll have more hip pain than they had when they try to go back to running during postpartum because of a lot of these postural adaptations that happen during pregnancy. So ligament laxity and the postural changes that come with pregnancy can be a magnifier, allowing movement to happen where it shouldn't. So we're going to talk a little bit about that and then the risk that come along with it. Early postpartum is the time for rebuilding our deep core system. So the abdominals had months to adapt to the growing link tension relationship during pregnancy. All right, so it really is great to explain to a woman, think about how long it took your abs to stretch out to this point. Now we need to give them some time to come back along with some exercises to help assist. So after delivery, a woman is presented with very lengthened abdominals and fascia with no pressure to help them function well. Because if you think about it, the baby being in there creates its own pressure. And so we have pressure against the lengthened abdominals. And then all of a sudden postpartum, the pressure, the baby that was providing the pressure is gone. And so it can feel very disconcerting to our deep core system trying to work. The managing expectations is extremely important in this time period in a woman's life because there's so much pressure to get your body back after baby, so much pressure. And this pressure can be very detrimental because women will often jump into exercise that's far too hard for them so that they can, get back to where they think they should be when in reality, we need to give it a lot more time. So women who exercise during pregnancy can be the most vulnerable because the rest of their body feels amazing and ready to go. And what we have to explain to them is that they have to give their pelvic floor and core time to catch up. So even though they were in CrossFit and they did their CrossFit WOD the day they delivered, it doesn't mean that a few weeks later they can go back to doing the same thing. All right. So we've got to give the body time to readapt. So help them handle that pressure to get back into pre-baby state, help them prevent skipping steps that might end in more major injuries down the road. So I do like to think of pregnancy as an injury. It is a wonderful, natural, amazing phenomenon. But when we think about it, it comes with negative tissue adaptations that allow for delivery. So we don't put an ACL repair athlete back on the field to go full force in a few weeks. We give them time to heal and specific protocols and exercises. So we should give a postpartum woman the same treatment. Right. So major concerns postpartum, we have lengthened muscle tissue, both in the abdominals and the pelvic floor. We have changes in resting position of the diaphragm and pelvic floor due to the baby, widening rib cage, pelvis changing to prepare for delivery. This changes our breathing and our abdominal stability system. So a lack of a ZOA, that zone of apposition, and changes in the ISA, that's our infrasternal angle, that's the angle that the rib cage makes, and our pelvic outlet and inlet alignment due to muscular length changes. So all of the things that we kind of line up to be able to produce force, make sharp turns, and do that without bothering a knee or a hip hurting us or having low back pain, they all get kind of changed with pregnancy. Right? So it creates local areas of weakness, increases risk of diastasis recti, hernias, prolapse, and pelvic floor dysfunction, and it decreases support for other areas, leading to substitution and changing strategies that can create tightness and pain. Things such as clenching glutes, overactive paraspinals, abdominal gripping. I mean, even just something as simple as abdominal gripping can lead to lots of neck and shoulder pain. So we have these issues that we can prevent and help women take care of. All right, so how do we handle this recovery process? We treat it like a process. All right, so some athletes can return to the field of play very soon after their ACL reconstruction, and some take a lot longer. Now, I like to refer lightheartedly and with good nature to the women that I talk to. They're like, well, I started running 2 weeks postpartum. And I'm like, you are a magical unicorn. And then they laugh because I'm calling them a magical unicorn. So we hear those stories. We hear the stories about the postpartum Olympic athletes that competed in their sport 6 weeks after giving birth. And I like to think about those women as being the magical unicorns because it's amazing and that's truly great, but most women cannot get away with that. Right? So most women should wait 4 to 8 weeks, and some need to wait a little bit longer before doing more higher impact exercise. So we'll go through that. But help a woman know that maybe if she had a magical unicorn pregnancy, delivery, the first go round, it doesn't always mean that it happens in the subsequent pregnancies. So I see a lot of that in my practice as well. So women who were fine with the first one and then ended up with prolapse with the second one because they came back too soon or leaking or some other issue that they didn't have or they didn't even know they should think about. Okay, so which recovery timeframes matter? The first 3 to 4 months matter for building that solid base, dealing with hormones and lengthened tissue. After that, the person's capabilities and foundation matter more than the time frame. Okay, so this is really important because some women just never built the base strength in the first place. So their body has to learn how to find that base strength, how to find that alignment that helps optimize the pelvic floor and diaphragm before they can move forward. And some women have had it and they just need a little reminder and a little time for tissue healing. All right, so our main goal is to establish a great base of strength and movement patterns to get the pelvic floor and core working properly through rib cage pelvic alignment, and then progress smartly, which sometimes you got to hold people back a little bit and sometimes you got to push them forward. I've seen people that want to sit at more of that low level rehab exercises and then they wonder why they're not getting anywhere. All right, so what to avoid those first 6 weeks to 4 months postpartum, or maybe sometimes longer. Hard plyometric type exercises, jumping jacks, burpees, jump roping, box jumps. I just kind of take them straight off the table. I'm not a huge fan of running in the first 6 weeks, either hard biking or hard swimming, or even honestly hard elliptical where a person is really going above 80%. Front abdominal exercises need to be done with caution. I usually try to avoid them in those first 6 weeks. But if somebody is feeling good and they are feeling strong and they want to work more on those front loading abdominal exercises, then I just make sure they understand how to spot abdominal bulging, how to identify diastasis so that they can be responsible for their body as they move into these harder exercises. So basically maxing out or pushing over 80% is something I try to hold people back from, because when we max out or go in those higher levels, we create tremendous amounts of intra-abdominal pressure. And especially if there was a vaginal delivery, the pelvic floor just might not be ready to handle that amount of intra-abdominal pressure. So breastfeeding matters. All right. So it extends time for ligament laxity postpartum because of hormone imbalances. So estrogen remains low as long as prolactin is high. Hormones improve with 3 or fewer breastfeeding sessions a day. So that's what this old study that I found said. Believe it or not, there is not a lot of research in this area. Who would have thought? But I can say from my personal experience with both of my children, it took me much longer to feel the downslide of hormones post breastfeeding. I had to quit completely. Even I could still feel some laxity in my system when I was down to 2 feedings a day. So all that to say is that everyone is a little bit different, but make sure when you're talking somebody through healing these postpartum issues, make sure they know that breastfeeding is amazing, but also don't expect things to come back completely, that there's still a very large window for healing that can happen. All right, so family history is very important. I usually have patients ask their parents, their mom, their dad, to ask, think back to their side of the family, grandparents, if they're still alive. Does their family have a history of hernias? You'll find one side of the family where everybody had to have hernia surgery. You might find out your grandmother and your mom had an early hysterectomy due to prolapse because you asked. And these might not be things that were talked about before asking. So a strong family history should lead to additional caution postpartum. We can overcome our genes to some extent. But if we have a tendency toward these issues, then we just need to know it and we need to use extra caution coming back. So I usually try to keep these women from maxing out, running or jumping until they are finished breastfeeding or past 1 year postpartum, unless they are super strong and have shown me that they excel at pressure management. So this is incredibly important. I don't want them to look back on it and think, I caused my prolapse because I tried to do something too soon. So just trying to keep them a little extra cautious, because if they know that they are prone to hernias, then that's something that we can help control. That's something that we can work on pressure management with them. And I feel like it's an amazing preventative strategy coming postpartum. All right, so just because you have the genes doesn't mean you can't overcome them. All right, so when is it safe to start impact activity like running? I mean, that is the number one question, right? When can I go for a run? All right, so that is a loaded question in my book. And I'm pretty sure there are people who have never had children that really shouldn't be doing higher impact exercises because frankly, they just don't have the strength to support it. All right, so it's not a matter of when, it's a matter of what in my book. So what does your base strength look like? Can you do a small single leg squat without me seeing a bunch of knee valgus and a hip drop? Like, do you have some base strength there? Can you eccentrically load into the posterior chain? How is your foot and calf strength? What are you bringing to the table for pelvic stability? So I want to see them show me that they are strong enough to run before I'm going to give them that okay to run. Because think about it, if they don't have the muscular kinetic chain, all right, from the feet all the way up to the hip, to the abdominals, to support that single leg impact that happens with running, what do you think is happening to the pelvic floor, right? It's feeling increased stress. It's feeling increased strain. So the pelvic floor has a tendency to pick up the slack for what's not happening at the hip. I see a lot of women with pelvic pain and pelvic floor tightness, and a lot of it has to do with the pelvic floor compensating for weaknesses in the other part of the system and has nothing to do with their pelvic floor, other than their pelvic floor is trying to pick up the slack. And then they go and overload it with something like running. So we just need to look at the system as a whole from both a women's health perspective, but also an orthopedic perspective. So core and pelvic floor prevention. This I love being able to get my hands on somebody before they're seeing me for an issue. All right, so teach breathing and pressure management strategies. So you want to rewire those patterns that can get a little bit wonky with the postural changes from pregnancy. Monitor for signs of bulging and doming and diastasis. And I love teaching women how to do this, what it is. It just empowers them. They are in charge of their body now. Decrease or eliminate exercises that produce straining during this time period. And that could be, maybe we need to look at how we're putting the baby and the car seat into the car or throwing the stroller in, because that is an activity that increases strain. So start with easy volume, weight, and then progressively increase. Pay attention to exercise strategies and form execution. So it's not always what we do, it's how we do it. So bearing down can be a shortcut strategy for stability and strength that can have long-term consequences, right? So catching these patterns early and changing them can really prevent a lot of heartache. I like to think about it as peeling back the layers. So the diaphragm and pelvic floor coordinate and work together. So when you inhale, so our diaphragm sits in this dome-like shape. And when we inhale, our diaphragm contracts down. All right. So as our diaphragm contracts down with our inhale, it puts pressure down on our internal organs. And so when that happens, they move into the pelvic floor. So our pelvic floor sits here and it kind of catches our organs, catches that pressure, and we get a little bit of a give in the pelvic floor. And then we go back up to resting tone and we go back up to resting diaphragm position. All right, so we get this nice coordination that happens. So what I find with a lot of postpartum women, especially those that are dealing with prolapse, is they don't have that coordination. So they're in more of a shallow inhale. They don't get that really good diaphragm expansion. And then so their pelvic floor can get a little bit reversed with their breathing pattern, which can then increase pressure down and how we're modulating the pressure. So most postpartum women have a wide ISA. So this is a wider infrasternal angle. That is going to mess with how their diaphragm helps to control intra-abdominal pressure. So normally a wide ISA correlates with an anterior pelvic tilt. So think basically we are opening in the front for this. So if we have a wide ISA and an anterior tilt, we are opening in the front. Okay, so that is what normally happens. But with these postpartum women, we'll see them grip and tuck with that more wider ISA. So they end up kind of hinging out with their wide ISA, but a gripping and tucking happening here. But with that said, they still have all the same issues that someone does in an anterior pelvic tilt. So they lack core strength, they lack adduction, range of motion, because the pelvis tends to sit more in that forward anterior pelvic tilt, and they lack posterior mediastinum expansion. They can't get the back of the diaphragm to move really well, just like someone and sitting more in an anterior pelvic tilt would. So they often have compensatory patterns of stiffness or gripping for stability versus dynamic control and good resting posture and tone. So what I see in postpartum is layers on top of layers. So you take the normal stuff that we learned for orthopedic patterns, and then we put on this whole other layer that goes on top of it. And so it's just, it can be really overwhelming sometimes, unless we can tackle this with helping women with this postpartum time period. All right, so for rehab purposes, thinking in the layers, I like to find the abdominals, so get them to find those TAs, and then start working on a 360 breathing. Now, most of the moms I know are a little bit overwhelmed during this time period. And so I really like to get them doing something called side breathing. So there's lots of exercises, but side breathing is kind of fun, because it's going to be something they can do while they're waiting. They can do it while they're leaning over a crib, rubbing a baby's back. So they can do it, mix it in during the day instead of me saying, okay, dedicate this exercise time, which often doesn't happen, right? So you're going to pretend that you are a teapot and you are going to tilt yourself over, but not directly sideways. You are going to go a little bit to the front. So you're going to tip forward and tip sideways. So this is kind of like, think about pouring out at a diagonal angle. So think I'm pouring out diagonally. We're going to tighten, scrunch, squish the front. So squishing in, we are lengthening and opening the back. Great for postpartum women that have back pain. And then we're going to give a big inhale into this back and side right here. So try it with me. So big inhale into the back and side. And you can feel how, oh, does that feel really tight? Am I not getting anything to move? Then you might need to not bend over quite so much. Don't put quite so much stretch until you get a little bit of tissue expansion ability in here. So inhale, big expansion. You can do the other side. Squish, teapot, over, inhale. Get that great expansion. So they can do this during the day. It makes it really easy. And then they're just going to feel great because their back is going to start moving. They're breathing. You're feeling for the ribs. When you do this exercise, you're feeling for the ribs really traveling out to the side. Because when we breathe, We want to get that nice 360 expansion of our rib cage to allow for that diaphragm to move well, because we get that really great exhale, we can get that really great inhale, and we get lots of dynamic diaphragm motion. All right, so next, do they need to find hamstrings or glutes? Okay, it's usually one of the two. All right, so we need hamstrings to position the pelvis, assist the abs, help the deep hip rotators like the piriformis and obturator vein kind of let go. And we may need hamstrings to help find abs and get the paraspinals to let go. This can be a big one in the postpartum population. So we need glutes to help center the femur in the socket for hip extension and to stabilize and move the pelvis. So if the hip flexors are driving the role for stability and pelvis movement, then deep hip rotators will be on all the time to counter that pull. There is so much tightness that is often in the back of the pelvic floor for postpartum women. All right, so we want to get this to calm down. So it prevents them from lengthening to allow for eccentric hip hinging control. So you see these women and they don't know how to do a hip hinge. They can't get any eccentric glute length. They can't get eccentric hamstring length, and they just scrunch. They grip their glutes, tuck them under, create more tightness, and go from their low back. And then they have low back pain at the end of the day. Finding the rib cage stack over the pelvis helps to better assess glutes and deep core and functional activities. Then once we have this, think about this, we're moving through layers here, right? So we're kind of peeling back the layers. We're looking at abdominals, we're looking at breathing, we're looking at the pelvis. And then once we kind of have a few of those things in place, then we're going to work on the untwisting, which, hey, that's probably the reason why they came to see the physical therapist in the first place, right? Is because they're maybe having some SI joint pain or something else, and they've got a rotation happening in their pelvis. So I like to think about these layers, because if I just try to unrotate, they're just gonna go right back. Then we'll just get that recurrent pain. All right, so let's talk a little bit more about pelvic floor dysfunction, diastasis recti, and returning to sport. All right, so what do I mean by pelvic floor dysfunction? So we have stress urinary incontinence. This is leaking from impact or from intra-abdominal pressure. We have urge incontinence, which is an overwhelming urge to urinate, but it may or may not leak. We have pelvic organ prolapse. This is where the pelvic organs descend into or out of the vagina, or they are pulled down due to tightness. So I see both kinds of causes of prolapse. I can see prolapse from fascial stretching, levator ani tearing, lack of support. And then I also see prolapse that is caused by maybe scar tissue that needs to be released, pelvic floor tightness. So on one kind of prolapse, I see more of, kind of think about it as an accordion and folding, the accordion folds when you kind of bring it tighter together. And so this kind of prolapse kind of makes more folding. So then we see that lip of that prolapse, that bulge hanging out because we've pulled things tight. And then we also have the other end, though, where women have experienced complete muscle tearing or loss. And then we've got a lot of fascial lengthening or stretching. And then we're going to have a bulge from that fascial stretching. It is often pretty easy to figure out which one it is, because doing lots of Kegels can help with the fascial laxity, because we're going to increase that muscular support to come in and kind of pick everything up. And likewise, if somebody's just dealing with tightness or needs some scar tissue release, then doing Kegels is obviously going to make them a lot worse. And then you can have layers on top of that. So obviously you can have fascial stretching, tearing, and tightness on top of fascial stretching and tearing, which is sometimes the most disheartening to have to tell people, because I usually have to say, okay, we're going to relax your pelvic floor, get some length, work on the scar tissue, and then your prolapse is going to feel worse, but then it's going to get better for the long haul as we work on strengthening on top of that. So really helping to prepare them for, all right, things might look a little worse, or they might get a little bit better. I don't know. And so just helping them prepare for that. All right. Dyspareunia is quite common. This is pain during sex, pain with penetration, because the pelvic floor muscles can rebound. So think about that stretch reflex. Think about sometimes we extremely stretch a muscle and it's like, and it comes back very tightly. And so painful sex can be incredibly common postpartum, and women just think it's normal. So just, even if you're in a complete orthopedic setting, just maybe mention like, hey, these are some of the symptoms in the pelvic floor that we're looking for. Do you experience any occasional leaks when you cough and sneeze? Or, sex should not be painful. Can we talk about that? So you can just kind of put it in there into that conversation in your intake. to find out what they're dealing with. Pain, heaviness, tightness, these are all things that can be improved. All right, prevalence of diastasis recti, 60% of women at 6 weeks postpartum and 32% at 12 months postpartum. Another study showed 100% of women at their due date had a diastasis recti and 39% at 6 months. So you can see how it's going to resolve pretty early naturally for some women. Another study showed that 6 weeks postpartum, 15.9% of women without a diastasis had pelvic organ prolapse versus 4% in the group with a diastasis. So could it be that those who reestablished intra-abdominal pressure before their pelvic floor had a chance to heal are at greater risk for pelvic organ prolapse? Maybe. So I see diastasis as a way for pressure to get out the front. I see the pelvic floor as a way for pressure to get out the bottom. And so whenever we are really good at knitting one of those and decreasing the pressure leaks, if we want to call it that, from one spot, it's going to exponentially increase in the other spots. So this can just be something to keep in mind. I also often see women with a diastasis recti that have tight pelvic floors. So just a little thought there. All right, let's do a quick anatomy review when we're looking at diastasis. So we have two sides to our abdominal wall that connect in the middle. This midline fascia is called our linea alba. And the linea alba is where the diastasis recti happens. Okay, diastasis recti is just a thinning of this linea alba tissue. So we have 3 layers of lateral abdominal muscles. We have our external obliques that come in like putting your hands in your pockets. We have our internal obliques that are like putting your hands in your inside jacket pocket. And then we have our transverse abdominals, which are more like that corset that squeezes you. Okay, the rectus six-pack, rectus abdominis muscle sits up the front. And it is encased with a rectus sheath from the aponeurosis of the 3 lateral abdominals. So this aponeurosis is what forms that linea alba, which is pretty cool. So when you think about it, that midline fascia is formed from our lateral abdominals as well. And so that's pretty neat. All right, so I think that that is something to think about when we are helping women with diastasis. All right, so in order to check a diastasis, you want to barely lift your head, place your fingers, and I like to check right underneath the rib cage a little bit, so an inch or so below the rib cage, an inch or so above the pubic bone, like halfway between their belly button and their pubic bone, and then right above their belly button. Most women have diastasis recti issues right above their belly button. So you just barely lift the head, and what you're feeling for is the space and depth between the rectus belly. So you have your 2 rectus abdominis bellies, and then you place your fingers between. Obviously, it's a subjective without an ultrasound because all of us have different hand sizes. But what matters is, are you seeing improvements in the person? So your hands stay the same. So that measurement will stay consistent throughout your treatment period. So you've got that measurement and you're looking at width and you're also looking at depth. All right, so do they dome or sink? So how does their core respond? So the most common diastasis variation that I see in athletes, both men and women, is a doming out of their midline. So you can check out this picture over here because athletes generate pressure. And this is a lack of pressure. This is an excessive amount of pressure. I really think it's important to check a diastasis in all positions, along with feeling their diastasis for width and depth. You also want to look for doming and rectus bulging as well, because that's giving you clues as to how well their lateral abdominals are coming in and coordinating with their rectus and balancing that strength. So they might be great on their back, but really bad in a plank, or they might be bad on their back and great in a plank. I once had a patient who's like, I want to do this workout. And I was like, I don't know, you're still not looking great. And I was like, show me the exercise. Let's check it. And when she did a plank, it was amazing. She felt and looked phenomenal. Her diastasis knitted together really well. She had no bulging and it was nice and firm. And I was like, this is great. Your body overloads and handles that demand really well. So I think it's important to check women in different positions and different amounts of load instead of just assuming that they're not going to do well. But we also want to check, because I've seen a lot of women who check their diastasis postpartum. It wasn't really that bad, like 2 fingers, 2.5. And then they went and did some get their abs back, abs class, and then ended up with a 4-finger width, super deep diastasis because they overloaded too soon before the tissue was ready. All right, so when we think about working on our core and diastasis recti healing, the external obliques layer on top of the rectus. So this sheath is firmly attached to that rectus muscle. The TAs layer below the rectus, and this posterior sheath is not firmly attached, suggests a slide of movement. The internal obliques split, some go above, some go below, and this can change throughout the rectus abdominal muscle. So you might get more layering on top of the TAs and IOs when you go down lower into that rectus sheath. All right, so you're trying to bring tension to that transverse abdominal sheath, and it's going to involve getting tension there is going to involve more than sagittal plane muscle training, I think is the point I wanted to make with this, because we look at all these women lying on their backs doing all these crunches, and they're in the sagittal plane working primarily rectus and struggling to bring in those lateral abdominals to help contain things. All right, muscle shape changes over time. This is something really important to keep in mind. So in newly postpartum women, the rectus was thin, the cross-sectional area was wide, the rectus became thicker over time, and interrectus distance decreased. Muscles need time to heal after getting stretched out. This seems obvious, right? It does. It just seems obvious. So this presents the case for not jumping back into exercise that's too hard too soon. So tissue adapts to stimuli. The key is the right amount of stimulus. We want to help it along with exercise stress so that we get positive adaptation, but not so much that it gets worse, obviously. All right, so a mindful core strategy. So loading thin, lengthened tissue too aggressively leads to further damage. Backing off during pregnancy as doming or linea alba distension is observed is a great rule to follow to help promote better postpartum recovery. So if you can, get yourself to get a hold of these pregnant women and teach them how to monitor what's happening at their linea alba so that as that changes during pregnancy, they can know when to back off. And then you just want to come back slowly postpartum, starting with low load and then building as tolerated. So where's that line for low load versus high load? That's obviously going to depend a lot on the person, but use caution trying to get abs back at the cost of the pelvic floor is my advice there. So without balancing out the bottom of the core canister, you can put tremendous pressure down on the pelvic floor. So can they breathe as they increase load? Do they have eccentric abdominal control? This is breathing under a brace. All right. Do they have good ribcage pelvic alignment to help with managing that pressure? So does diastasis recti abdominis weaken pelvic floor function? This is an interesting question because you see all the ads everywhere on Instagram and Facebook. They're like, fix your diastasis to fix your pelvic floor. Well, that's an interesting thought, but that's not what the research is showing. So this study looked at 310 women. They were checked between 6 and 8 weeks postpartum. They were evaluated for POP, SUI, and pelvic floor strength and looked at diastasis width. The limitation, obviously, looking at width and not depth as well. All right, so what they found, I included the study because I just thought it was very interesting with lots of interesting takeaways. So a high BMI was a protective factor for diastasis, but a risk factor for pelvic floor dysfunction. A lower BMI, a greater number of gestational weeks, and a higher birth weight increased diastasis risk. The amount of pregnancy weight gain was not a factor for diastasis. Faster postpartum weight loss was a factor for diastasis. C-section was a risk factor for diastasis, and vaginal delivery was a risk factor for pelvic floor dysfunction. I mean, those two things kind of make sense to me, right? You have a C-section, we're at risk for diastasis, but that doesn't mean that you are not going to have any risk of pelvic floor dysfunction. All right, so most notably was the increase in hiatal dimensions. All right, so women with a diastasis were not more likely to have weakened pelvic floor muscles and increased urinary incontinence or pelvic organ prolapse at 6 to 8 weeks postpartum. So diastasis and pelvic floor issues are not correlated. All right, so this was one more thing that pulled out of the study that I thought was so interesting for takeaways that I wanted to share with you, because I just think the numbers and stats are really fun because it kind of gives us a look at, all right, let's assume that we need to ask questions. All right, let's assume we need to check for things. All right, so 1 to 3% of women with a C-section had pelvic organ prolapse. 21 to 24% of women with a vaginal delivery had pelvic organ prolapse. I've seen research studies that show up to 50% of women have pelvic organ prolapse, will have pelvic organ prolapse at some point in their lifetime. All right, 3 to 7% of women with a C-section had urinary incontinence. 8 to 13% of women with a vaginal delivery had urinary incontinence. So I just want us to take a moment and appreciate how much more common having pelvic organ prolapses than having stress urinary incontinence, because you have everyone talking about stress urinary incontinence and not as many people talking about prolapse. And these women are living with stigmas. No one's talking about it. And they're wondering, why did this happen to me? Why am I so alone? And they are not alone. 41% of women with a C-section had a diastasis recti, and 30% of women with a vaginal delivery had a diastasis recti. So diastasis recti is also very common. You should be checking everyone that walks in the door, including men. I have treated a lot of men that had a diastasis recti. So average baby weight for diastasis and no diastasis. So it is interesting how baby size for that made a difference. So stress urinary incontinence prevalence and pelvic floor strength in athletes. So the prevalence of urinary incontinence among athletes was 52%. All right, so since we're talking about a back to sport population here, 52% is really high. So this author showed the prevalence of urinary incontinence can range from 28 to 80% in sports such as trampolining, gymnastics, aerobic gymnastics, hockey, and dance. So basically places where we're moving our body in ranges of motions with high intra-abdominal pressure. So the incontinent athletes were able to generate a stronger max contraction, which is really interesting. And I think makes treating this population so fun, because then we're looking at, all right, if they had a stronger pelvic floor contraction, what is happening in the rest of the system? What's happening with their abdominal balance to create the situation? All right, so age factors. So a likelihood of a major levator ani deficit is less than 15% for mothers aged 20 years compared to 50% or more for 40-year-olds. All right, so women with a levator ani deficit are about twice as likely to have recurrence of pelvic organ prolapse after surgical repair. Women with levator ani deficits are also the highest group to have pelvic organ prolapse. And the research is showing us that they don't recover as well from surgery, like they have rebound and prolapse. And so my thought with sharing this was to say there's a lot of women who give birth, and there's a lot of women now that are older that are giving birth. And, you know, those older women are the ones who are more likely to seek help with us for physical therapy. And so making sure that we're screening for that, we're getting help, we're referring them back in to maybe get some imaging, and just know that the likelihood of a levator ani deficit is very high among older mothers. All right, so association of pubovisceral muscle tear with functional capacity of urethral closure. This is another one of those tearing that we need to pay attention to. So women with a pubovisceral muscle tear achieved a 25% lower urethral closure pressure during an attempted pelvic muscle contraction than those without a tear. So urethral closure pressure is the number one predictor of stress urinary incontinence. Okay, so this is where, even if we have a tear, sometimes internal release work can be amazing for helping with scar tissue, helping with muscle alignment, and helping us with recruitment of other muscles to help take the place. Right, so the influence of pelvic repositioning exercises on pelvic floor muscle asymmetry. Now, this is one of my favorites. So when we talk about peeling back all those layers, right, we got to the last layer. Right? And so this study is really interesting to me because I've done a lot of work on the orthopedic side of pelvic floor issues, where someone has been to see someone for internal release. They've been to see their pelvic floor PT for internal release, and then the internal release didn't work or didn't stick, and they're right back to where they started. So I get to look at it more from the outside perspective, which is really fun. And so this study looked at testing range of motion, Oberst, Thomas test. They used an ultrasound to get a picture of the pelvic floor at rest, and then max contraction of the pelvic floor. And what they looked at was displacement of the bladder. So the bladder borders did not line up when they contracted their pelvic floor. So both groups showed a right to left length of asymmetry regarding the bottom border of the bladder. So they did 15 minutes of repositioning and breathing exercises. And then the pelvic floor muscle contraction symmetry improved after these pelvis repositioning exercises in the experimental group only. So pelvic floor muscle contractility, the bottom border bladder displacement improved after exercises compared to baseline. So sometimes it's not the pelvic floor. all that to say, sometimes, I mean, these people doing more Kegels would not have helped one iota, not even a tiny bit, because it had nothing to do with their pelvic floor that was changing their contraction. It was the alignment of the pelvis due to muscular influences outside the pelvic floor. All right. I thought this was very interesting and something I find very fascinating when I'm looking at why someone is leaking. So jumping versus Valsalva. So there was a study that showed a difference in intra-abdominal pressure development, intra-abdominal peak values, and pelvic floor deformation patterns. So jumping is not the same as a Valsalva. Valsalva is when you hold your breath, and Valsalvas can actually be done safely with training. It's also been shown. So I am not one of these people that are completely against the Valsalva if it is done responsibly with training. All right, so jumping had more compressive force against the pubic bone, which is a weakness of an intrinsic sphincter closure system, not the pressure itself. So it had more to do with our neurological response than actual muscle strength. Okay, now we can change how nerves influence muscle by changing alignment and compression on nerves and recruitment. So all that to say, everything also goes into working on nerves. But a Valsalva, think hold your breath and do a deadlift, had more to do with downward pressure force than it did the neurological side of things. Okay, so this is where we want to look at pressure management for athletes. So is there a safe version of the exercise? Can I just tell my athlete, oh, modify it with this? So the research says that no differences in intra-abdominal pressure were found between the recommended and discouraged versions of the same exercise for all exercise types. Okay, so it's all in how you do something, not what you do. Right? So we have to pay attention with the form that people are using to do things and how they are managing pressure in these exercises. So do you have a timing issue, strength issue, or a pressure coordination issue? And that is what we are investigating. So for my kind of general postpartum screening, if someone is not coming in with a very specific issue and we're doing kind of more of a general screen, then I like to look at how's their overall stress and support at home. What are their goals? How do they feel? I mean, these are going to be very different exercise prescriptions for what we're giving people at the ends of these spectrums. So what was their general fitness during pregnancy? Any pubic symphysis pain or SI dysfunction? Did they have a C-section? Have they been taught scar massage? Can they get a balanced TA contraction? Okay, back on that scar massage, we should be teaching all women that have had a C-section self-scar massage, because think about it. Any point we have a scar, we're going to get a pulling, right? So you can have bladder pain, you can have front pelvic floor pain, you can have leaking, you can have urinary incontinence issues and urge incontinence issues from that scar from the C-section if it's not released, because it can create a pulling on the front, which can then create some tightness. All right, so can they get that balanced TA contraction, or do they have really weak lower TAs and really strong upper middle TAs? It creates a cinching effect down on the pelvic floor. Can they contract their pelvic floor? What does it feel like? Any pelvic floor issues they're aware of? I usually like to just start throwing out ideas for people. These are pelvic floor issues. All right, so do they have any tearing? Did they get internal pelvic floor PT yet? Release work is very important. All right, so do they have a diastasis, and do they understand what distortion in their diastasis looks like? Are they able to check and monitor for demming? All right. I like to check breathing on everyone, and I like to observe posture. I like to observe posture more as how did they walk in the door? How did they get up from their chair? How did they bend over to pick up their pocketbook? More in a natural environment than stand and let me look at you, but you can find a lot from the stand and let me look at you. All right, so postpartum recovery and return to exercise. I really wish there was a one size fits all, like here, do these 3 exercises, but someone dealing with a diastasis will need a much different focus than someone dealing with levator ani tearing. So even with diastasis healing, someone with an upper diastasis will need a different focus than someone with a lower diastasis. So we're looking at changing ISA versus the infrapubic angle to influence changes in the abdominal wall. So with that said, there's some general considerations that everyone will need. Think of it as boxes to check. If they can't check the box, then I'm going to need them to extra focus in this area. And with that, I like to think in layers. Can they breathe well? How's their rib cage and pelvis alignment? Can they manage pressure? Do they have base strength for the chosen exercise? And that seems like common sense, but it is something people don't think about. And are they doing just simply too much too soon? They don't have that base in place. So once you know that the basics are in place, you can move on to more advanced strategies and advanced exercises. I also want to make sure that I give a nod toward the biosocial model integration. I have just learned through working with many, many people over the years how important the biosocial model is. It gives women and men and everyone, it gives us the freedom to explore and face fear. If we can't explore and face fear and the things we're afraid of with our body, then we're not going to make much progress. So pelvic floor dysfunction can be very scary. So if they can't let go of that fear, then they can't move forward. So I want to say that with really being careful with our language. So our word choices matter. Language can be very damaging. So I want to say things like improve or explore instead of fix. I want to say, prolapse is something that can be improved. I have seen so many women improve their prolapse. So don't strip away someone's hope with always and nevers, but do give them the tools to pick better goals. So goals that relate more to function than metrics can be very helpful. Fear creates tension, hyperfocus, anxiety, and depression, right? So I do love meditation because it does help us connect and feel our body, which can be really good. But I've also found that women who deal a little bit with a higher anxiety side, I want them to be a little careful with being too introspective with meditation. So there's a fine line between feeling and obsessing, and trying to get women to not check their prolapse 18 times a day to see if the state of their prolapse has changed and things like that, where we need to learn to let go a little bit while we learn to feel and give our body lots of grace. So learning to let go can be helpful. So meditation can act as journaling to help us process and let go of those feelings. So basically help them kind of understand what they're feeling and then let it go. Or maybe a movement meditation where they're focusing on connecting with their body versus letting them go a little too introspective. All right. Thank you so much for joining me. I was asked to put together a 20-minute presentation, and I'm afraid I went a lot longer than 20 minutes, but there is just so much to talk about, and this topic is so passionate to my heart. I would love to share more with you. My website is coreexercisesolutions.com, and I have a ton of free resources, free videos, articles. So head over there, and there is lots more to follow up with on specific exercises, video demos, all kinds of things like that. So thank you so much for joining me. I really appreciate your time, and I appreciate your interest in joining me to help women everywhere.